Yes.
Yes, sir. Yes.
Uh, okay, so probably this is one of the very basic question that many of our colleagues are thinking about, that why it is important to evaluate the bone loss and how actually to do this that is my topic. So if you see the world of shoulder instability surgery is divided into two groups. One group, they do Latarze, the French group, where probably Karthik is standing at this moment. And the other side is the Bankart group, where Vivek Pandey and people like me are standing. And we are very proud of a new technique, relatively new, which is remplissage, which we think that if we supplement with this, probably the results are going to be better. So the division is made by practically by the bone loss and some other issues also, but bone loss is the main indicator for deciding what type of surgery is going to be done. So why it is important is there is a concept of a critical bone loss. So critical bone loss means the amount of bone loss which will definitely impact on the decision making and the functional outcome of a particular surgery. So if the critical bone loss is less than the desired, then there is a low recurrence rate of Bankart repair and there is a good functional outcome. But if the bone loss is higher than the critical bone loss, then high rate of recurrence with the Bankart repair and poor functional outcome, and probably a Latarze procedure has been debated for all these patients. So what is the critical bone loss? As we saw, Karthik was showing his critical bone loss was glenoid index. He said 0.8. That is how he decided. That means for him, critical bone loss is about 20%. There are Easy Toys and some other paper who say that critical bone loss is about 25%. So 25% who will decide either to go ahead with the Bankart repair or with the Latarze procedure. This is a little old, and then subsequently after this, there are some other papers also. So this is redefining the critical bone loss. And this paper says that it is not the 20%, it is not the 25%, probably a subcritical amount of glenoid bone loss of about 13.5% also have a poor, more than 13.5% also have a poor outcome with the Bankart repair. So one important thing is the bone loss that everybody has to measure, that many of the surgeons they suggest. So when we talk about measuring the bone loss, you can measure in the glenoid and you can measure in the humeral head as well. That means a Hill-Sachs lesion. And there is another concept. So if you combine this humeral bone loss and with the glenoid bone loss, then this gives a concept of a bipolar bone loss that I will also talk about, and then this will give rise to the on-track and the off-track concept of the Hill-Sachs lesion. So how to assess the glenoid bone loss? It can be assessed in X-ray, it can be assessed in the CT scan, and it can be assessed in the MRI as well. And of late, many people are assessing in the MRI. This is a X-ray, which was a Bernagy view, which is used to be done. I'm not going to this one because I don't believe that many people use this to assess the glenoid bone loss. The most commonly done is the CT scan. So there are values of 2-dimensional CT scan and there are values of the 3-dimensional CT scan. I'll not go into detail, but CT scan by and large at this moment is the gold standard for the measurement of the bone loss. So how to measure the bone loss? Karthik was also saying, Dr. Vivek was also saying that glenoid index is one of the most commonly measured index in the CT scan. So this is a picture. This is a 3D picture. I'm going to show a video how to measure the glenoid index. This is right and the left. So to measure the glenoid index, basically you need both sided shoulder. So you need a right side shoulder as well as left side. So this is important to know that when you advise or when you recommend for shoulder, you have to suggest to take a en-face view of bilateral glenoid. Then you mark the superior glenoid tubercle and the apex and draw a vertical line. Once you have drawn this vertical line, mark a point which is junction of inferior 2/3 and the middle 2/3, and at that point you draw a perpendicular line to the previously drawn line. So this is a perpendicular which is about 31 millimeter. So you do the same thing on the other side. 2 points. One is the supraglenoid tubercle and the inferior one. Then again mark the junction of the inferior and the middle two-third, and then draw a perpendicular line to that, and you measure this thing. So it will come around, so 21.9. So once you have this both measurement of both the side, you can calculate the glenoid index. This is 21.9 divided by 31. So this will give rise to a glenoid index, which is in this particular case 0.7. So how you can calculate a bone loss from this glenoid index is, so the normal glenoid width was 31. The affected side, the glenoid width was 21.9. So that means there is a 9.1 millimeter of the bone loss. And this 9.1 millimeter is about how much percentage of this 91% of the 31 normal glenoid is about 29.35. So this is the way you can calculate a glenoid index as well as the bone loss in that particular shoulder. My favorite technique is a perfect circle method. This perfect circle method is easy because you don't need to do a MRI of the other side and doing a CT scan of the other side on first view. The only affected side will be enough. So here I am trying to show the video. You mark same the point, the superior glenoid tubercle and the 9 o'clock position in this side. So you make a perfect circle which touches the inferior pole and the 9 o'clock position. So this is the perfect circle that you have created. Now you can measure the whole diameter. So this will give you a normal width of the glenoid, the supposed to be normal width of the glenoid, which in this case is about 4.2 centimeter. And then you can measure the loss part. So from the edge of the glenoid to the edge of the circle. So this will give you about 0.7. So once you have measured this, both the loss and the present, then you can go and calculate your bone loss. So 0.7 is lost, and this is about 16.66% of the 16% of the bone loss. So this is a perfect circle method. The third method is a pico method. Again, in this method, this measures the volume of the loss, and this requires CT scan on first view of the bilateral shoulder. So how I do it? So first you measure in the normal side, you need both the shoulder 3D reconstruction on first view. You put a perfect circle. Yes, please.
Can I interrupt you for a while?
Yes, go ahead.
The line method which you took from top to bottom, and the the ratio of the width, and then the circle method you were showing on screen, how are you doing? Are these the same patients?
No, these are the different patients.
Okay, because it looked the same. Because what I understood, you see, when you do the circle method, the chance of error is very high.
Very
and if
true.
you do the line, compare with the other side, the much more closer.
Very true, very true. So I'll come to that. So you take a circle from the normal side, and then you take you put it on the affected side at the same size circle, copy and paste, and then you can mark this empty area, and this your software of the CT scan computer will calculate the volume of the loss. So this part of the glenoid is lost, and then using those things, so how much volume is lost from the glenoid and the total volume of the glenoid, then you calculate your bone loss. In this case, it is 26%. So coming to the humeral side, again in the humeral side also you can measure in the X-ray, you can measure in the CT scan, and you can measure in the MRI also. I have no experience of measuring all these things in MRI. The CT scan by far is the best. If you read the Boleu's paper, when he said that ISIS scoring system, he said that probably if you can see the Hill-Sachs lesion in external rotation, that is a significance. That say that probably an X-ray can also be used to measure or quantify the Hill-Sachs lesion. These are the X-ray technique, which is known as a radius technique, by which you can measure all these things. I'm not going to that, but the easiest technique is known as the funky pizza technique. So in this funky pizza technique, you create a circle and divide this circle into 8 slices. So each slice means it is 12.5% of the bone. Now you take the CT scan where your Hill-Sachs lesion is the largest one. the cut of the CT scan where the Hill-Sachs lesion is largest one, and then you paste your funky pizza out here and then adjust so that it matches with the circle of the head. And now you can see that this is one slice of the pizza, which is about 12.5% of the bone loss. What is it's important is various. There are so many things. Some have given a classification. This is Bigliani's classification, in which they say that if there is less than 20% loss, it is mild, moderate, and severe. And probably if there is more than 30%, they need treatment. I don't know this based upon just the CT scan. Coming to the bipolar concept, bipolar is a very interesting concept. If you see this first X-ray in which there is no bone loss, but there is a Bankart lesion. So if there is a Bankart lesion, that means there is no anterior strain. This Hill-Sachs lesion is going to engage. But if you repair the anterior Hill-Sachs, anterior Bankart, probably this Hill-Sachs lesion is not going to engage because there is a anterior strain. Now, even after repair, suppose that there is a bone loss on the glenoid side. So even if it is repaired, the bone loss will create such a situation that these Hill-Sachs lesion will engage. And this is the concept that not only the bone loss into the glenoid side, but also bone loss into the humeral side is also important. And this is the concept developed by E.G. Itoi and the group which is known as the bipolar lesion. So what is the glenoid tract? A study done by Yamamoto, they say that the glenoid tract is a contact surface into the humeral head of this glenoid. So in their study, they said that about 80% of total width of the glenoid comes in contact with the humeral head. And this contact area is known as the glenoid tract. So if you consider this is the glenoid tract, and this is the Hill-Sachs lesion. If your Hill-Sachs lesion is within the glenoid tract, then they are known as the on-track Hill-Sachs lesion. If your glenoid lesion is outside the glenoid tract, they are known as the off-track Hill-Sachs lesion. And this is the basic concept which many people nowadays use to decide either to do with what to do with the Hill-Sachs lesion. Another important thing we have to understand that if the glenoid is normal, the same Hill-Sachs lesion may be on track. But now you see the same picture. Now this shows that if there is a bone loss like this, the same location, same size Hill-Sachs lesion, if it is associated with the bone loss, then this becomes a off-track lesion. And this is the very important concept that has to be understood. So how to measure the bone tract, the glenoid tract? And again, I need 3D reconstructed film on first view of both the glenoid and the posterior aspect of the humerus where you can see the Hill-Sachs lesion. So how I measure is, I again do measure the width of the glenoid. So this is the normal side. The width of the glenoid on the normal side is 24 millimeter. Here it is 22 millimeters. So now you can see that the bone loss is about 2.1 millimeters. So this 2.1 of 24 gives rise to a 8.5% of the bone loss. So now the glenoid width of the bone loss area is 22.6. So 84% of 22.6 give rise to you a figure which is known as 18.76. So glenoid tract of this particular patient or that shoulder will be 18.7. Now what you do is you draw the Hill-Sachs lesion, you mark the Hill-Sachs lesion and put your 18.7 into here. So now if it falls within the tract or the Hill-Sachs lesion is within this region, that means it is on track, or if it goes outside, then it is a off track lesion. So as Vivek was also trying to say that how this can be simplified, if your glenoid tract is more than the Hill-Sachs lesion, so in this particular case, the glenoid tract is more than the Hill-Sachs lesion, probably these are on track lesion. If your glenoid tract is less than the Hill-Sachs lesion, so you measure from the footprint to the medialmost border of the Hill-Sachs lesion. If this is less than the glenoid tract, probably these are the off-track lesion. This is how you can measure the on-track and off-track. And based upon that, there are treatment paradigm that has been given again by Giovanni, Itoi, and Burkhardt. You can decide what type of surgery will be suitable for that particular patient. However, Before concluding, these are 2020 paper in which they have doubted what is the accuracy of currently available method in quantifying anterior glenoid bone loss. And unfortunately, they say that there are various methods and its accuracy cannot be judged. So we cannot say that which one is the best method by which you should measure a glenoid bone loss or a humeral side bone loss. This is another paper, a very recent one, 2019, says that the measurement of bone loss may not be very useful because this may not be accurate, and the critical bone loss we have not yet defined, so it may not be very useful. So coming to the end, this is just like an anti-climax when you say that there are so many methods, there are so many ways you can measure, and at the end of the day, when you come to know that probably none of these are very accurate and sharp, so we are lost and we don't know what to do. So to conclude my presentation, I would like to conclude by saying that bone loss is only objective criteria which helps us in guiding the treatment option. So at this moment, we do not have other good criteria except the bone loss. There are various methods of bone loss measurement exist, and none of these have shown significant superiority over others. So probably using one or two odd method may be a good idea to do, and probably we'll listen from our panelists, which will be a better one. Although estimation of bone loss is very important for decision making, it is not the only factor. So other factor also has to be taken into consideration when you talk about the bone loss. So this finishes my presentation. Thank you very much for patience listening, and hope there will be some question to discuss. Thank you, Dr. Nagmani, if you are there. Otherwise, Vivek, you
Yes,
can
sir.
take it further. Yes.
Thank you, sir.